Hello, future nurses. This is Professor Flourish. Today we're going to be talking about antineoplastic drugs. So these are the drugs that we typically use for oncology, cancer. So these are our cancer agents. These are just some general cancer terminologies, mostly so that way when you're studying this, when you're looking through this, you understand what we're talking about. Like carcinogenesis just basically means cancer developing with changing of normal cells to cancer cells. So you can see it called like cancinogenesis, oncogenesis, malignant transformation. All of these three terms mean the exact same thing. And what we're saying is something's forming a cancer. Metastatic tumors or secondary tumors are cancerous tumor cells that move from the primary location by breaking off from the original group and establish remote colonies. So when we start getting more, I guess, nervous about cancer, it's when it has metastasized. Ploidy is a description of cancer cells by chromosome number and appearance. So this, I'm not going to go through all of these, but this is just different types of carcinomas, just so that way you know where they're kind of developing from. Like, for example, lymphomas arise from lymph tissues. So usually we name our cancers from where they derive from. These are some more cancer terminologies. Alopecia is that loss of hair. Cachexia is extreme tissue and muscle wasting due to malnourishment. Emptogenic, a substance that can induce nausea and vomiting. Extravasation is the leakage or infiltration of vesicant into the surrounding tissues. So this is for our IV medications. They can be very destructive to the patient's tissue if it leaks outside of the vasculature. Nadir is the period in which the bone marrow suppression is the greatest and the patient is at highest risk for complications. So this is the lowest level of neutrophils reached during therapy. So at this point, since we've got a little bit of neutrophils, because this is the lowest level of neutrophils, we're very concerned about our patient's ability to fight off infection. So like I said, these are all just general terminology that we use during our cancer treatment. So we're going to first start out with chapter 45, which is our antineoplastic drugs. So this is a cancer overview and cell cycle specific drugs. So cancer is that cellular transformation. It can have that uncontrolled and rapid cellular growth, invasion into those surrounding tissues, and metastasize to other tissues or organs. Cancer cells do not have growth control mechanisms. So that's one of the characteristics of them is they can't turn off the amount that they grow. Positive physiological function. So it's almost like I'm sending all of this nutrient into this bubble that's not actually helping out my patient. So we're just kind of using resources instead of helping. Cancer cells either grow and invade adjacent tissues or break away from the original tumor mass and travel by means of blood or lymphatic system to distant sites. So we get very concerned when the cancer actually moves from one area and travels elsewhere. This is some more just terminology for it. We've got the primary lesion, which that's where I was talking about that lymphomia, where you talk about where it started out. So that is the original site of growth. Metastasize is uncontrolled cell growth. Secondary lesion is a new and remote part of the body. Neoplasm is new tissue, so that's mass of new cells, tumor. And then you've got two different types of tumors. We've got benign tumor and malignant tumor. So benign tumor is basically this growth of substance, basically. I don't know how else to describe it, but it's basically this growth that's not spreading. While it can hinder on possibly on perfusion, just depending on its location, it's not spreading, it's just kind of growing in a kind of controlled area. When it becomes malignant, that's when we get nervous about it because now it's spreading. So grading is how we kind of see how bad this cancer is. So grading classifies cellular aspects of the cancer. Fluidity classifies the number and structure of tumor chromosomes as normal or abnormal, and staging classifies clinical aspects of the cancer. So with both fluidity and grading, these ones are basically saying what type of cancer it is itself, like who's involved. While staging is how much medical treatment are we giving this patient? So we'll kind of focus on this grading versus staging. So some cancer cells are more malignant than others. This is where I was talking about some are a lot more dangerous than other ones. Well differentiated means that the cells look like normal cells and tend to grow slowly. So these are your benign tumors. These are the ones that we're not as worried about because they look like normal cells, they're confined, they're controlled. Undifferentiated or poorly differentiated means that the cells do not look like normal cells and tend to grow quickly and spread. So these are the ones we get concerned about because it's moving the cancer from somewhere like the bone all the way to somewhere like the lungs. So this one's spreading and we're getting more deformity of our cells throughout our entire body. So this is the basic grading system of malignant tumors. Grade X cannot be determined. Grade 1 tumor cells are well differentiated and closely resemble the normal cells from which they arose. This grade is considered a low grade of malignant change. These tumors are malignant but relatively slow growing. So as you can see, they get kind of worse and worse depending on our grade. So like grade 4, tumor cells are poorly differentiated and retain no normal cell characteristics. Determination of tissue of origin is difficult and perhaps impossible. So grading is actually looking at the cells itself and saying, okay, this is what these cells look like. They no longer look like their original cells. They now look like this deformity of a much different type of cell. So we're looking at basically tissue on grading. Staging is that clinical process. And the staging system we usually use is the tumor nodule metastasized system. So tumor is basically the tumor of origin, the primary tumor, where it all started. Node is how many lymph nodes are involved, and metastasize is the presence of distant metastasize. Like, are there different organs involved in this? And I've got an example that I'll show you that'll make it a little bit more clear. So on here, you can see where they're kind of staging it of either whenever it's X, that just means that we cannot assess it. So we don't actually know who's involved with it. And as we go on, we can see that increasing size of the primary tumor, or if it's in the situal or where it's located. I like this chart a lot because it kind of pulls into what I was just talking about. So stage 1, so this is how we're staging, and we're using prostate cancer. So stage 1 of prostate cancer, the cancer is small and only in the prostate. So on this stage, we could just remove the cancer and then we'd no longer have the cancer, or through theory, we would no longer have the cancer. Stage 2, the cancer is larger and may be both lobes of the prostate, but is still confined to the prostate. So that means that it's moved a little bit to the lobe. So we're getting concerned of this spreading. Stage 3, the cancer has spread beyond the prostate to closed lymph glands or seminal vesicles. So this basically means that it's spread outward and now it's getting into our lymphatic system. So now we're getting in concerns of if it's moving into our lymphatic system, then it can get somewhere else. Stage 4, the cancer has spread to other organs such as the bone and is referred to as metastatic cancer. If prostate cells spreads or metastasizes to the bone, you have prostate cancer cells in the bone, not bone cancer. So this is kind of like an important concept to be able to regulate within yourself, just so that way you're giving good patient education if they talk to you about it. If you have, it all comes back to the primary tumor. Who is involved with this primary tumor? So wherever the cancer starts is the kind of cancer you have. Now, prostate cancer can metastasize all the way to your brain, but that doesn't mean you suddenly developed brain cancer. You still have prostate cancer. It's just prostate cancer that's metastasized, because it all comes back to what the cells look like. This right here are what's it called? Like neuro cancers, like the classification of tumors by tissue of origin. So neuro, you could have nerve tissue, neuroma, neurofibroma. So those are your benign ones, and the malignant ones are your neurosarcoma. So basically just kind of showing you the tissue of where it first started, and then there's the cancer. So your paraneoplastic syndromes are various groups of symptoms that cannot be directly attributed to the spread of a cancerous tumor, caused indirectly by substances produced by a tumor or part of the immune response to it. So this may be the first signs of malignancies. You've got cachexia, which if we look back at our terms here, we can see what that means. Cachexia is that extreme tissue and muscle wasting due to malnourishment. Because basically the way these cancers work is they're taking all of your electrolytes, they're taking everything you have and giving it all to this cancerous cell that's all developing. So you almost have this like wasting syndrome where everything is malnourished because it's all going to feed this cancer. Now, the problem with it is that cancer doesn't actually have any functionality. So it's just basically like I'm putting all my eggs in this basket that's not going to actually work. Fatigue, fever, and weight loss. Once again, anything I eat is going to the cancer instead of going to help out where I need it to help. So these are the 7 warning signs of from American Cancer Society. Caution is what they usually use. C, changes in bowel or bladder habits. A sore that does not heal. U, unusual bleeding or discharge. T, thickening or lumps in the breast or elsewhere. I, indigestion or difficulty swallowing. O, obvious change in a wart or mole. N is nagging cough or hoarseness. And other manifestations are things like weight loss, fatigue, weakness, pain, nausea, anorexia. So those are all your signs of cancer. Some etiology can be things like age, sex-related differences. For example, you can't have prostate cancer unless you have a prostate. So same thing with you can't have ovarian cancer unless you have ovaries. So that's why they say that sex-related differences. Genetic factors, some people are just more inclined to develop cancer. Ethnic factors, oncogenic pathogens, so things like smoking, occupational environment carcinogens. So if you work in a place like a coal mine, you're more likely to get lung cancer. Radiation. So some of the people who are more susceptible to things like radiation would be those healthcare workers that work with cancer patients because they're working with radiation. It puts them at a higher risk of developing these cancers. And immunologic factors. So things like, do you have HIV? Are you immunocompromised? Is it allowing these things to develop that probably wouldn't have developed had you had a strong immune system? So this is the cellular growth cycle, mostly because the reason I talk about this is because this is where our different antineoplastic medications actually affect. So we've got our G, resting phase, G1, first gap phase, S, synthesis phase, G2, second gap phase, and then M is mitosis phase, cell reproduction. So what happens is a lot of times there's a dysfunction within a cancer cell that causes them to have an issue with the cell reproduction. So they'll keep on producing and producing and producing, and there's no actual stop. So what a lot of these cancer agents do is try to stop somewhere within these cell growth cycles. Now, this is still a field that's being studied, so there are going to be changes with it. So just if this is something that you're really passionate about, I do say continue to kind of update of what's changing with this. So some of our cancer treatments are things like surgery. You can actually remove it. Radiation. So I always say like zap it because you're basically using like radiation to kind of shrink the chemo agent, or sorry, not chemo agent, shrink the tumor, and then chemotherapy. So what chemotherapy is using medication or drugs in order to destroy the cancer. So that's where we're kind of stay with these. So malignant neoplasm is more technical term for cancer. Antineoplastic drugs are drugs used to treat cancer. They're also called cancer drugs, anti-cancer drugs, cytotoxic chemotherapy, or just chemotherapy. So with chemotherapy, it's the pharmacological treatment of cancer. You'll have antineoplastic drugs, and it's usually divided into 2 groups based on where in the cellular life cycle they work. So that's why I showed you that cellular life cycle, because it'll show you the different cycle, and that's how these agents work. Cell cycle non-specific means that there's not a specific area, and we'll talk about this more as we continue. Cell cycle specific, there's a specific area within the cell cycle that they're going to hone in on or attack. And then subdrugs have characteristics of both. So you can have some that are both specific and non-specific. Oops, sorry. So this is just a video that I think is kind of helpful. Oops, we won't watch it right now. Sorry. Just because sometimes the audio doesn't work too well when I try to put it on here. But it is a helpful video that kind of shows cancer and like the history of cancer. It's only 5 minutes. Okay, so cancer drugs, antineoplastic medications. So our CCS, these are our cell cycle specific drugs. Drugs that are cytotoxic during a specific cell cycle, used to treat a variety of solid or circulating tumors. Antimetalobites, mitotonic inhibitors, alkaloid topoisomerase 2 inhibitors, topoisomerase 1 inhibitors, and antineoplastic enzymes. So those are the ones that fall into these categories. Then the other ones we have are our cell cycle non-specific drugs, cytotoxic during any cell stage. So these are our miscellaneous cell cycle specific drugs, our miscellaneous antineoplastic, so cell cycle specific is unclear, hormonal agents, radioactive antineoplastics. So with chemotherapy, drugs have a narrow therapeutic index. Combination of drugs is usually more effective than single drug therapy. So we want to hit different portions. So with these patients, they're usually using a variety of drugs. They can develop drug resistance, so you just want to be aware of that. And nearly all drugs have adverse effects. So one of the hardest things is keeping our patients adherent to this. And they also have that dose-limiting adverse effect. If you remember in our HIV conversation, dose-limiting basically means that there's only so much of it that we can give them before we're causing more damage than helping. So chemotherapy are harmful to all rapidly growing cells, harmful cancer cells, healthy, normal human cells. So this kind of helps you when you're trying to study of what are your signs of symptoms or what are your adverse effects for chemotherapy agents. So think about all the cells in your body that are rapidly growing. That's hair follicles. Your hair is constantly growing. Gastrointestinal GI tracts and bone marrow cells. So your hair follicles, if I'm not growing those as quickly, that's where I get that alopecia. So I get that hair loss. Gastrointestinal cells, that's where I'm getting that nausea, that vomiting, those GI upsets, because once again, I'm not having as much cells within that GI. Bone marrow cells, that's where I'm getting that myelosuppression. So I'm getting bone marrow suppression, bone marrow depression. So that means that if I'm suppressing my bone marrow, that means that I'm losing things like my white blood cells, higher risk for infection, my platelets, higher risk for bleeding, and then my red blood cells, higher risk for anemia, because I'm not having that ability to transport oxygen. So when you study it, think about that it's attacking all rapidly growing cells, and it kind of helps you to see what your adverse effects and then what you're going to do for them. So that dose-limiting adverse effects, once again, it's that GI tract and bone marrow. We don't want to completely destroy our GI tract, and we also don't want to completely destroy our bone marrow, so we have to be careful with these drugs where we're not giving them too much. Alopecia, usually you want them to pick out a wig before they start losing their hair. Eptic potential, so they're very highly risked that they're going to be throwing up. Myelosuppression, so once again, bone marrow suppression, bone marrow depression. Nadir, which is that, remember when we look back, let me pull it back here, because that's that lowest amount of neutrophils. So if you want to go back to, oops, where is it? I skipped it. Okay, nadir. So the period in which the bone marrow suppression is the greatest and the patient is at highest risk for complication, lowest level of neutrophils reached during therapy. So this is basically when your patient is at the highest level to develop infection because they've got the lowest level of neutrophils. And why is that important? So you can kind of pause the video and think about why that is important. And it's important because we're putting our patients who are already kind of trying to fight this huge tumor, we're placing them at a higher risk of developing infection. So that's why we put patients on neutropenic precautions. That's why we're trying to keep them safe from what we have. Extravasation is basically when a, when a cancer agent gets into the tissues, so it completely destroys the surrounding tissues. So even while you might not be giving the IV therapy yourself, you do want to know for the signs and symptoms of what extravasation looks like. That way you can stop the agent and let someone know if you're working with them and you're not directly the one giving the chemo agent. Targeted drug therapy, once again, we're trying to hit where the cancer is actually developing. This is a picture of extravasation. You can see that it started in probably a 20 or a 22 here, or maybe even an 18. And it wasn't going into the vasculature, instead it was going into the tissue. And this is very toxic to tissue, because remember, these cancer agents destroy all rapidly growing cells. So when it got into the skin here, it just basically eroded all of this area here. So as soon as you see signs and symptoms of that, that's why we're so like, turn off the, the pump and see what's happening, because this medication is not actually getting to the patient, so it's not actually helping the patient. So special considerations are toxicities like counterindications, pregnancy, pubertal. So are they before puberty, and older adults? So these are things that you just want to take in consideration. Like for your older adults, is it worth putting them through all the struggle of having these chemo agents, and kind of looking at it that way? So your cell-specific anti-metallobites, they antagonize the actions of key cellular metallobites. Anti-metallobites work primarily in the S phase of the cell cycle when DNA synthesis is most active. So these anti-metallobites are usually working in the S phase. So you can have things like your folate antagonists, methotrexate, which methotrexate we also use in rheumatoid arthritis. So that's why with rheumatoid arthritis, a lot of times, since we know that it's going to be antagonizing folate, which folate's used to help make, what's it called? Hold on, think I'll pause for a second. Sorry, I thought somebody was coming in. But folate is used for the development of red blood cells and forming that DNA. So a lot of times if somebody's on methotrexate, they'll also put them on folic acid. Purine antagonists, so these are attacking our proteins, and pyridium antagonists. So yes, we've got folic acid antagonism interferes with the use of folic acid. As a result, DNA is not produced and the cell dies. Purine antagonism interrupts metabolic pathways of purine nucleotides, results in interruption of DNA and RNA synthesis. And with these ones, you can have that tumor lysis syndrome, which we'll talk about in just a bit. Pyrimidine antagonism interrupts metabolic pathways of pyrimidine bases, results in interruption of DNA and RNA synthesis. So these drugs are usually used in combination with other drugs to treat various types of cancer, such as solid tumors and some hematological cancers, acute and chronic lymphocytic leukemias, colon, rectal, breast, stomach, lung, and pancreatic cancers. They've got oral and topical forms, may used for low dose maintenance and palliative care therapy, often used in combination with chemotherapy regimens. Methotrexate is also used to treat severe cases of cirrhosis and rheumatoid arthritis. Some of your adverse effects, remember, this is attacking all fast-growing cells. So it can be hair loss, nausea, vomiting, myelosuppression, neurological, cardiovascular, pulmonary, hepatobiliary, biliary, GI, genitouria, dermatologic, ocular, optic, and metabolic toxicity. So when you look at these adverse effects, that's why I said we kind of want to watch which patients we're going to be using our chemotherapy agents, because this can be a lot. Tumor lysis syndrome, which I'll talk about in the next slide. Palmar-Plantar dysesthesia, also called hand-foot syndrome, Steve-Johnson syndrome, and toxic epidermal necrolysis. So those are some of our skin disorders we can get with it. So tumor lysis syndrome occurs when the chemotherapy successfully destroys a cancer cell. So yes, it's good that we destroyed the cancer cell. However, if you remember from what I said before, is that cancer cell has just been developing with all of our electrolytes, with all of these substances. So when it basically pops, it results in that release of all these intracellular components, such as potassium, phosphate, and uric acid, into our bloodstream, which can be very harmful because that's all of a sudden like getting a huge, what's it called? A huge portion of potassium. We're getting a huge portion of uric acid. So our primary concerns are hyperkalemia resulting in lethal dysrhythmias. So for them, we're going to use our loop diuretics, because if you remember, what do we lose with our loop diuretics? Potassium. So for that hyperkalemia, I'm going to use a loop diuretic. Hyperuricemia resulting in acute kidney injury, so I can use allopurinol. Hyperphosphatemia results in acute kidney injury and dysrhythmias. I can use my phosphate binders. And hypocalcemia results in tetany and dysrhythmias, so I can give them calcium. So that's what happens with that tumor lysis, is the cancer cell bursts, and now I'm in an oncological emergency. So these are kind of like our emergency drugs for this cancer. And there it is where it's actually showing it. And so which condition does the nurse anticipate when assessing a patient who has tumor lysis syndrome? Yes, hyperuricemia. And with that, we're going to give that allopurinol. So metonic inhibitors are natural products obtained from pinkerwinkle plants. Yeah. So these can work in various phases of the cell cycle, late S phase throughout the G2 phase and M phase. All work shortly before or during mitosis and thus slow cell division. Each different subclass inhibits mitosis in a unique way. So it's often used in combination with other therapies, and it's used to treat a variety of solid tumors and some hematological malignancies. Testicular, small cell, lung, breast, ovarian, non-small cell cancers, Kaposi sarcoma, which that's the HIV, or it's AIDS. That's one of the indicators that somebody's moved from HIV to AIDS, is seeing these Kaposi sarcomas. So that's a cancer that's usually limited to HIV or AIDS. Acute leukemia. Adverse effect, there we are, we're seeing those same adverse effects again. Hair loss, nausea, vomiting, myelosuppression. You can also have liver, kidney, and lung toxicities, convulsions, so seizures, extravasations. So there are several specific antidotes that can be used. So when in doubt and you know that your patient has had extravasation, let provider know, let pharmacists know, so we can give them the right medications to fix and save as much tissues as we can. Alkaline toxopherase 2 inhibitors are used to treat small cell lung cancers and testicular cancer. Not used as much now because of the significant toxicities without therapeutic benefits. Topsomer 1 inhibitors are used primarily to treat ovarian and colorectal cancer, derived from the capnexin, a substance taken from a Chinese shrub. Other two medications. These are cell cycle specific drugs. They inhibit proper function of DNA in the S phase, prevent DNA regulation, and indications are your ovarian, colorectal cancer, small cell lung cancer, and often tumors. Adverse effects, Topkin is BMS, mild to moderate nausea, vomiting, diarrhea, headache, rash, muscle weakness, and cough. Irinotecan, Causes are more severe adverse effects, such as your hematological adverse effects, cholinergic diarrhea, moderate risk of nausea and vomiting. Antineoplastic enzymes are synthesized using cultures of bacteria and recombinant DNA technology. As a result, an enzyme is produced. The enzyme is isolated and purified for clinical use. So for asparaginase, it's used to treat acute lymphocytic leukemia. So basically what they do is they kind of get that enzyme in order to help with that treatment of these cancers. Indication, treatment of that lymphocytic leukemia. Adverse effects are things like impaired pancreatic function, which leads to hyperglycemia and several severe or fatal pancreatitis, dermatologic issues, hepatic, GU issues, GI issues, neurologic, musculoskeletal, and cardiovascular. So what are your nursing implications? Assess baseline blood counts before administering antineoplastic drugs. You want to know how many white blood cells does this patient have. Follow specific administration guidelines for each antineoplastic drugs. I cannot stress this enough. Make sure you actually read how it is to be administered, especially for some of those oral medications. If it says wear gloves, make sure you are wearing gloves when you give it to them, because some of these you can get particles on your skin and it can end up damaging you. Because remember, these are very strong medications. Same thing with if it needs to be kept in the dark, keep it in the dark. Remember that all rapidly dividing cells, both normal and cancer cells, are affected. So your mucous membranes, that's when you're going to get things like stomatitis, which is basically a bunch of blisters in your mouth, hair loss, bone marrow competency. Monitor for effects of these tissues or complications. So monitoring for complications, your GI mucous membranes, that's where I was talking about that stomatitis. You'll also see it called mucoitis. Basically what that is that I've got a bunch of blisters all through my mouth. Altered bowel function with high risk for poor appetite, nausea, vomiting, diarrhea, inflammation, and possible ulcerations of the GI mucosa. So this video here is like a helpful video where it shows things to avoid, because if you've got all this mucitis in your mouth and you've got all these blisters in your mouth, you don't really want to be taking in citrus with it for that stomatitis. So just being aware of that. You want to monitor for complications. Once again, that loss of hair, alopecia, bone marrow components, dangerously low, can be life-threatening. Monitor for adverse effects specific to the type of antineoplastic drug used. Implement measures to monitor for and prevent infection in patients with neutropenia or leukopenia. Implement measures to monitor for and prevent bleeding in patients with thrombocytopenia and anemia. Keep in mind that anemia may result in severe fatigue. So trying hard not to get your patients to do too much in a short amount of time. Okay, so the nurse is caring for a patient who received chemotherapy 24 hours ago. The patient's white blood cell count is 4,400. Which symptom, if experienced by the patient, should the nurse report to the prescriber immediately? So this is a patient who has what? Below normal white blood cells. So they're already neutropenic. So if they're neutropenic, then I'm thinking about my white blood cells. So what I'm going to be concerned about more than anything else is a fever, because a fever in an immunocompromised patient can be considered deadly. So monitor for stomatitis, that oral inflammation, ulcerations, and implement measures to reduce the effects if it occurs. Anticipate nausea and vomiting and implement measures to reduce the effects. Antiemetics often work better if given 30 to 60 minutes before chemotherapy started. So make sure that we're giving things like ondansetron before our patient actually has their chemotherapy, because we don't want them to feel sick during it. We want them as comfortable as possible. Women of childbearing age will need to use non-drug form of contraception during therapy. In addition to physical measures, keep in mind the need for emotional support. This can be a very difficult time for these patients, so make sure that we're listening to their needs. Monitor for therapeutic responses to antineoplastic therapies and the many possible adverse effects. When working with a patient who is neutropenic, the nurse identifies which is the most effective measure to prevent the patient from developing an infection. Hand hygiene, without a doubt. Okay, so our next one is our antineoplastic drugs part 2. So these are our non-specific drugs. So cell cycle non-specific drugs are antineoplastic drugs, alkylating drugs, and cytotoxic antibiotics. Classic alkylators are nitrogen mustard. So that was that one that I showed you at the beginning. Nitrosources and miscellaneous alkylators. These work by preventing cancer cells from reproducing. They alter the chemical structure of a cell's DNA in bifunctional or polyfunctional. So they can have more than one function. They're used in combination with other drugs to treat various types of cancers, such as all of these following. So ovarian, brain, lymphoma, leukemia, breast, and bladder cancer. These have a dose-limiting adverse effect, so nausea, vomiting, myelosuppression, alloplasia, nephrotoxicity, peripheral neuropathy, ototoxicity. So the good thing is hydration can prevent some of that nephrotoxicity, but once again, if this is affecting our GI, we don't want the patient throwing up. So we can use things like 30 to 60 minutes beforehand using odastrone. Extravasation causes tissue damage and necrosis. And then here are some of our drugs that we would use for different ones. We can also use cytotoxic antibiotics. So these are natural substances produced by the mold Streptomyces. Semi-synthetic substances are also used. Bone marrow suppression is a common toxicity. Phyllomycin instead causes pulmonary toxicity, and donrupin causes heart failure. Doxorubicin causes left ventricular failure. So your non-specific drugs are active in all phases of the cell cycle. They act by intercalculation, resulting in blockade of DNA synthesis. And these are usually used in combination with other chemotherapy agents used to treat a variety of solid tumors and some hematologic malignancies. Your cytotoxic antibiotics expect bone marrow suppression, so that nausea, vomiting, diarrhea, and stomatitis. So for the most part, you've been seeing kind of a theme here. We're looking at all of our fast, rapidly growing cells, and that's where we're doing most of our treatment. Because remember, for these, try not to get caught up in the specifics of these chemo agents. First of all, they're always changing. Second of all, in order to give an IV chemo agent, you do have to be certified for these. So instead, focus on the things that we can manage. Monitor pulmonary status, because pulmonary fibrosis may occur. Monitor for nephrotoxicity and liver toxicity. Monitor your cardiovascular status. And do know rupicin may turn the urine reddish color. All can produce bone marrow suppression except blimyacin, hair loss, nausea, vomiting, myelosuppression, heart failure, acute left ventricular failure, pulmonary fibrosis, pneumonitis, liver, kidney, and cardiovascular toxicities, and a lot of others. Cardiomyopathy is associated with large amounts of doxorubicin. So routine monitoring of cardiac ejection fraction. Cumulative dose limitations, so not just giving them a bunch of the dosings. Cytoprotective drugs, such as dexraxian, can decrease the instances of this devastating toxicity. So alkylating drugs monitor for expected effects of bone marrow suppression, expect nausea, vomiting, diarrhea, and stomatitis. Hydration is important to prevent that nephrotoxicity. Report ringing or roaring in the ears, which is that possible ototoxicity. Report ringing, numbness, or pain in the extremities, which can be that peripheral neuropathies. Your hormonal drugs are used to treat a variety of neoplasms in both men and women. Hormonal therapy can be used to oppose effects of hormones, block the body's sex hormone receptors, and used most commonly as like an adjacent or palliative therapy. But it may be the first drug of choice in some cancers. And this is just kind of like our list of different hormonal drugs for female-specific neoplasms. These ones are male-specific ones. Once again, this is just about that extravasation. That's the leaking of antineoplastic drugs into surrounding tissues during IV administration, can result in permanent damage to the nerves, tendons, muscles, loss of limbs. Skin grafting or amputation may be necessary, and prevention is essential. So if you suspect that there is something going into the wrong area, stop the infusion immediately, contact the prescriber, but leave the IV catheter in. So that's the big thing. Continue monitoring of the IV site is essential. So the reason that we leave it in is because a lot of times they want to aspirate any residual drug. And sometimes what they'll do is they'll actually push the antidote through the IV line so it gets into the tissues. That's why if you see that extravasation, don't just immediately take it out. And sometimes if you put heat on it, that'll actually make it worse. Or if you put cold compress on it, that'll make it worse. So if you see extravasation, especially with the chemo agent, just contact the provider immediately. And there's that extravasation again. What is the primary action when a nurse is handling administering vasicant drugs? So for these vasicant drugs, you want to double flush the patient's bodily secretions in the commode. You want to assess baseline blood counts before administering antineoplastic drugs. You want to follow specific administration guidelines. And cytoprotective drugs may be used to reduce toxicities. So that's like that alperenol that we talked about before, where it's going to decrease the uric acid. In general, monitor for anaphylactic reactions, keep epinephrine, antihistamine, and anti-inflammatory drugs on hand, encourage the patient to eat small, frequent meals, and monitor closely for complications associated with that bone marrow suppression. So monitor for oncological emergencies such as infections, pulmonary toxicity, stomitis with severe ulcerations. So if they've got really, really bad blisters, bleeding, bowel irritability, renal, liver, and cardiac toxicities. All right, thank you all, and I will see you next time.